Thank you very much. So I'm going to kind of follow on what many of the previous speakers had spoken about. So visceral segment revascularization during repair of thoracoabdominal aneurysms requires a variety of innovative techniques. There are only one approved device currently, which is the Cook Z-Fin device. All the others are based on the individual physician's experience. There is one paper that actually compares fenestrated endografts to physician-modified endografts to Chimneys and snorkels. It is probably a little dated since it was published in 2019, but you can see as time goes on, the incidence of fenestrated endografts have slowly increased in time. Now, these are not really comparing, I'm not going to belabor you with all the data here, but these are not really comparing apples to apples. FEWARs are done in many centers. Physician-modified endografts are done in very experienced centers. At the time of publication, I think these were done in just about 6 centers. And Chimneys and snorkels, at least on this paper, was typically used for ruptured aneurysms. And they typically cannulated the SMA and one single renal. So they are comparing patients who are very high risk compared to fenestrated endografts, which is elective procedures. So looking at the complications, again, I think this unfortunately reflects the anatomy for which these different techniques were used. Perioperative death was highest for Chimneys and snorkels at about 6.1% and about 3% for FEWARs and PMEGs. Again, stroke, death rate, MACE, any complications were all much less for FEWARs and PMEGs compared to Chimneys and snorkels. And once you got over the initial complication rate from the ruptured aneurysms, the follow-up looked pretty stable. They're all very parallel lines. So just looking at that paper, what I concluded from that were Chimneys and snorkels are typically associated with the highest rate of strokes and major adverse event rates. No off-the-shelf devices are unfortunately currently available for ruptured aneurysms, and if you wait for an FDA-approved device, the lag time is usually about 4 weeks, which is for the Z-Fin device. None of the currently used devices, in my opinion, are optimal. Chimneys and snorkels, we use them as a solitary technique, often end up with multiple gutter endo leaks that are hard to treat, hard to image, hard to understand where they're coming from. Fenestrations, I think is a very a concept that is in infancy. It's a single circumferential point of contact for seals. If you really follow these patients long enough, you end up with junctional endo leak and significant branch vessel occlusions. So what do we currently use? So the way I look at it is we use a variety of techniques. I will occasionally, in a single patient, I will snorkel, I'll fenestrate, I'll laser fenestrate. So we try not to force a single technique on each patient. This is a patient on an excluded endograft placed about 5 years ago, resulted in a graft migration with a type 1 endo leak and a rupture. You can see the endo leak there, and the graft is below the renals, but we don't have enough of a seal zone if we deployed another graft below the renals. So the plan here was to laser fenestrate, which is currently my preferred technique for juxtarenal aneurysms. So we place initially balloon expandable stents in both renals. Then we place either a thoracic or an aortic cuff. I typically will use a Dacron-based system. And we balloon it once we place our renal stents. Then we laser fenestrate using a tour guide catheter or any of an angled catheters. It typically doesn't take a very long time. Usually about 20 minutes of renal ischemia time is what we encounter. Then we placed covered stents on both the fenestrations. And there's a completion angiogram. We eliminated the type 1 endo leak with good flow into both renals. Another very similar patient with a graft migration, type 1 endo leak. This patient actually had a prior renal stent. I think they had covered the left renal and placed a renal stent, but the graft subsequently migrated. So it became quite simple. We extended it proximally to the right renal. We were able to fenestrate into the left renal, placed a covered stent. Well, that's our completion there. I do carry, for emergency reasons, we carry a bunch of single SMA fenestrations on the shelf. I would recommend it for people who do complex rupture thoracoabdominals. This allows you to have a single fenestration, and then for the renals, I would either laser fenestrate or I would do a single fenestration and then a snorkel if necessary on the other side. So this patient came in with a ruptured juxtarenal aneurysm, had a very complex neck with a lot of calcium, so I was very worried about whether I'll be able to laser fenestrate into the renal. So I did place a snorkel. You can see a wire bond coming from above. And subsequently, I'm cannulating the SMA. I have made a single hole for the right renal that we were able to cannulate without much difficulty. And that's the completion angiogram. So we use a variety of techniques on the same patients. I try not to use more than one snorkel if I need to. I'm going to talk a little bit of a technique that I developed in 2009 called octopus endografts. I'm going to show you some examples. This became the foundation for Gore's TAMBI graft that's currently been approved, currently close to being approved. So the first was a 74-year-old male. He had a 6-centimeter thoracoabdominal aneurysm. He had an occluded celiac and right common iliac. He presented with a symptomatic thoracoabdominal aneurysm. So luckily, he had a very narrow neck proximally. We were able to use a standard AAA endograft, place it all the way to the left of the subclavian. Typically, I'll do a conduit in the left axillary artery to introduce my viabonds from above. And you can see from the first limb, I go into the SMA. The celiac luckily was occluded. Then we place another standard endograft to the prior endograft, extend one of those limbs into the right renal, and then I recanalize the right common iliac and then retrograde into the left renal. This is the initial diagnostic angiogram. The nice thing about coming from above is typically your wires will tend to go into the SMA or the left renal. So it's not a very difficult cannulation most of the times. Here you can see I'm in the SMA, and you can see filling of the celiac. We have the GDA. The celiac was occluded. That's a completion angiogram with all the branches. You can see how it resembles an octopus, hence the term octopus endograft was coined. Follow-up CAT scan, no endoleaks. Unfortunately, in our series, if you do see endoleaks, it's very hard to figure out where these come from, but luckily endoleaks are very rare. That's a subsequent follow-up CAT scan. It's another patient who had a previous repair by actually Sophie had done a thoracoabdominal repair, done a visceral patch. The left kidney got infarcted, was removed. Patient presented, I think, 15 years later now with a visceral patch aneurysm. And her creatinine was elevated. She was 7 centimeters. She had back pain. She was on home O2. So for her, we used something called a parallel endograph technique. We deployed true AAA endografts in the same location. Then I come from above. For her, remember, she didn't have a left renal, so all I needed was the celiac, SMA, right renal, and then the fourth limb will be used to extend into both the iliacs. So here's the technique. We come from above, place viabonds into the celiac, SMA, right renal, and then extend that into a standard endograft. There's the pre and the post, no endoleak. Follow-up CAT scans, we don't see any gutter endoleaks up top, and you can see all 4 limbs, which are widely patent with no evidence of an endoleak. You can also use a variety of techniques. You can place excluded endografts as an inverted fashion to cannulate the left renal. You can also place multiple viabonds inside the one limb. You can see all the configurations. It's totally up to your imagination. And that formed the basis for the TAMBI graft that I think will be approved pretty soon. So in conclusion, I tend to use Z-Fins when applicable. It's the only approved device. If we can wait for 4 weeks, that's my device of choice. For emergencies, we tend to laser fenestrate. However, we need more prospective randomized data looking for long-term patency. I typically will avoid multiple snorkels or chimneys, which I think most of us currently avoid doing. Endografts for thoracoabdominal aneurysms, unfortunately, still continues to remain in its infancy. Thank you very much.